The SENOMAC trial randomized 2,766 patients who had a primary invasive breast cancer and 1 to 2 sentinel macrometastases to either a completion axillary lymph node dissection or its omission. And then afterwards, most patients actually received nodal radiotherapy because they were treated according to standards of care in the country where they were randomized. And there was actually 5 countries. So not only Sweden, but also Denmark, Germany, Italy, and Greece. So overall survival was the primary endpoint, and we could, after now a median follow-up time of 60 months, not show any difference in overall survival between the 2 groups, 93.4 in the one group, 94.4 in the other group. So the hazard ratio is below 1 in favor of omission. So, but of course, the confidence interval process 1, but it confirms the non-inferiority by far. We had a non-inferiority margin of 1.44, the upper limit of the hazard ratio, and then we actually came up with 1.17. In terms of patient-reported arm problems, we see significant and relevant differences at all time points after surgery, with the group receiving an axillary lymph node dissection reporting significantly more problems with the arm. It can be pain, it can be swelling of the arm, but also functional limitations in their daily life.